mode.
Hello, everyone, and thank you for attending another CIFA webinar. My name is Tim Werner, and I will be managing this webinar today. Today we have Shel Levine from Eastern Michigan University. He's going to be doing a presentation on diabetes pharmacological update, old reliables and the new kids on the block. In the summary, he writes, the purpose of this webinar is to provide clinical exercise physiology professionals an understanding of the medicines used to manage type 2 diabetes. Obviously, clinical exercise physiology professionals understand exercise and its effects in patients with cardiopulmonary metabolic diseases. However, majority of these patients also have diabetes mellitus. While most clinical exercise physiology professionals may recognize names of diabetes medications, they may not understand their mechanisms of action, potential adverse side effects, and the implications these medications may have on existing patient and on their management of plasma glucose and hemoglobin A1C. So I would like to welcome Shel.
Thanks, Tim. Appreciate all the help you've given me getting set up for this, and look forward to doing this. Welcome, everyone. Here, I say welcome to the diabetic hotline. If you need a new excuse for cheating on your diet, press 1. Need a new excuse for skipping your workout, press 2. I use this slide as a intro because a lot of people with diabetes tend to be non-compliant with their management plan, and they're always looking for excuses, always looking for ways to get by on something. So that's basically what this slide means, is when you're working with people, you just know that they're looking for a way out. Type 2 diabetes, can't do any diabetes talk without a little epidemiology. And there's approximately 29 million Americans and about 412 million worldwide with diabetes. And it's estimated that about 50% of these are considered well controlled. And by well controlled, we mean maintaining a hemoglobin A1C level of less than 7%. Individuals with impaired glucose tolerance have already lost about 80% of their beta cell function. So diabetes is right around the corner. When diagnosed, essential for early pharmacotherapy to improve insulin sensitivity and preserve beta cell function is essential. As we all know, diabetes management is a balancing act. We're managing nutrition, exercise, medication, whether it's an oral medication or insulin, to manage and try to hopefully balance out blood glucose levels. Now, traditional treatment progressions for type 2 diabetes starts with diet and exercise. But like I say, a lot of diabetic patients are non-compliant with their treatment regimens. So diet and exercise traditionally fail. There's a few, I guess, that over the years will take to their diet and their exercise and stick with it and do well, but they're by far the minority. Once diet and exercise fail, oral hypoglycemic agents are initiated. And they are initiated when optimal glucose control cannot be achieved by nutritional control and regular exercise. Or if a patient is newly diagnosed and they're not really demonstrating a willingness to make lifestyle changes. A lot of people are ambivalent about making lifestyle changes. So oral hypoglycemic agents are initiated. They are first given out as monotherapy, one agent at a time. We'll talk about specific ones in a little bit, but one agent first. The problem with just starting with one agent is some people get the feeling that, okay, I have a medicine, I have a pill I can take, I can eat whatever I want. So a lot of times monotherapy fails, or I can stop exercising because I got a pill now. So monotherapy will usually fail. And a lot of time they will then enter combination therapy, which is two oral agents. Again, to oral agents sometimes fails. They just can't manage their diabetes properly. And then type 2 diabetics will become insulin dependent. So the term insulin dependent diabetes, while it definitely holds true for type 1 diabetics, also can adhere or also can relate to type 2 diabetics as well. So insulin is initiated in combination therapy, an oral medication with insulin. The overall treatment goal is to lower hemoglobin A1C levels below 7%. As we all know, a normal hemoglobin A1C is about 4 to 6%, and the ADA has recently determined that an A1C level of 6.4% is now a diagnostic criteria for diabetes. So even if they're 6.4 to 7%, they still have a diabetes diagnosis, but if they're in that range somewhere, it's still considered pretty well managed. Before we start getting into how the medications work and why they work, little pathology of hyperglycemia. Obviously, it involves a decrease in glucose uptake. We know type 2 diabetes, insulin resistance at the muscle, it's been drilled into us, right? But how does this insulin resistance occur? Well, one, we see a downregulation of available insulin receptors at the cell membrane. Okay, so there's just a downregulation, meaning there's fewer insulin receptors available for insulin binding. Okay, so that limits the ability of insulin to do its job. Also, we can see once if the glucose does bind to its receptor on the muscle cell, it has to get into the cell to carry out its action. And sometimes there is an impaired, what we call GLUT4. It's a glucose transporter molecule. It's called GLUT4, and it's charged with once the glucose binds at the receptor, it takes it into the cell through the cascade of reactions. Well, if we have an impaired GLUT4, that can also add to insulin resistance. The other half of impaired insulin action is insulin secretion from the pancreas. We have beta cell failure. Now, this is a little different. In type 1 diabetes, obviously beta cells are destroyed and there's no insulin being secreted at all. In type 2 diabetes, we have beta cell failure where, yeah, there's some insulin being secreted, but just not at the rate that it needs to be. And this stems from pancreatic exhaustion. What normally happens is, you eat a meal that's high in carbohydrate, obviously signals are sent to the pancreas, kick out insulin to go take out the blood sugar that's in the bloodstream. Well, so much is taken up, but there's still a lot of glucose left in the bloodstream. So another signal goes to the pancreas, hey, there's still glucose here, send out more insulin. So the pancreas sends out more insulin. And this keeps happening. So eventually, the pancreas just gets exhausted and the beta cells start to fail. And that's what happens there. A third pathology of hyperglycemia is what we call increased HGO, or hepatic glucose output. And this is where the liver overproduces glucose. Okay, we all know gluconeogenesis takes place in the liver, and the liver is just cranking out excess glucose. Now, also part of this is increased lipolysis. Fat cells are resistant to insulin. Fat cells that are resistant to insulin produce more free fatty acids, which in turn impairs beta cell function. So it limits the ability of the pancreas to secrete insulin as well. So the pharmacological mechanisms for the treatment of hyperglycemia are the follows. First, we need to promote glucose uptake. We need to stimulate insulin secretion. Sorry, I got ahead of myself here, sorry. These are insulin sensitizers. Okay, we need to promote glucose uptake with insulin sensitizers. Stimulate or promote insulin secretion, these are called insulin secretagogues. Okay, and these help to preserve beta cell function. We also try to decrease hepatic glucose output, decrease lipolysis, and decrease postprandial hyperglycemia. So the first drug, and these are the old reliables. Sulfonylureas have been around for a long time. They were the first drugs on the market to help treat type 2 diabetes, and they are an insulin secretagogue. So in other words, they stimulate insulin secretion, but they're only effective in the presence of endogenous insulin. So there has to be viable beta cells for sulfonylureas to work effectively. Sulfonylureas bind to the receptor site on the membrane of the beta cell. Okay, and they block potassium, they open calcium channels, leads to membrane depolarization, which therefore produces insulin production. Okay, there's an immediate first phase release. This is stored insulin. First phase insulin release is insulin that is stored in the pancreas, and then it also leads to extended second phase release, which is newly synthesized insulin. Now, the advantage of a sulfonylurea is that it's taken once a day. Okay, it's very economically effective. Just take once a day in the morning. However, the adverse effects of sulfonylureas is that they predominantly produce hypoglycemia because they keep working. Insulin production is glucose independent. They just keep producing insulin. Okay, and this is why it leads to hypoglycemia. Now, another form of sulfonylureas are referred to as non-sulfonylureas, but they're also called the Meglitinides. And Meglitinides have a similar action, but they're much shorter acting, and they have a different receptor binding location. Okay, like I said, they're very fast acting. They have a reduced risk of hypoglycemia because they're taken 30 minutes before a meal, and they work immediately after the meal and the snack. Right. The good thing also is you can vary your meal time or the number of meals more easily. And it works really fast, and your body uses it really quickly, unlike the sulfonylureas. Here's a list of sulfonylureas and meglitinides that are commonly used. The first generation of sulfonylureas aren't really used anymore. Diabinase, oronase, tolinase, just very rarely used. But the second generation, glipizide, glyburide, glimepiride, these are the generic names. Some of the trade names you might recognize: glucotrol, diabeta, okay, micronase. These are very commonly prescribed still today. Meglitinides, the big one is Prandin and Starlix, but Prandin is the one that's most commonly used today. Probably the most common diabetes medication on the market is the biguanide, metformin, or glucophage. Almost every type 2 diabetic, for some reason, goes on glucophage first. Very common and very commonly used with sulfonylureas. They are used in combination therapy together as well. The main action of glucophage is to decrease hepatic glucose output. And by itself, though, it is a weak insulin sensitizer. When it's used in combination with the sulfonylurea, okay, it enhances reduction in glucose levels, and it just increases insulin sensitivity. The benefits for metformin: a lot of patients will notice some weight loss at the start of therapy. And this is because there is a slight appetite depressant feel to the medication. Okay, it just tends to decrease appetite, and one of the reasons for the decreased appetite is it kind of does add some GI stress. That's at the beginning of treatment. Glucophage also helps to improve some lipid levels. Okay, they've seen the moderately decreased total cholesterol levels, triglyceride levels, improved HDL levels. And by itself, glucophage does not cause hypoglycemia. Right? That's a big big proponent there. And the other major aspect of glucophage is they have seen hemoglobin A1C levels that decrease by about 1.5 to 2.5%. It's one of the strongest, the greatest reductions in A1Cs that are out there, and that's why glucophage is so popular. Glucophage is also the first oral hypoglycemic agent to reduce MIs and diabetes-related deaths in the obese population, and this was data from the UK Prospective Diabetes Study. And as we'll see with a lot of the newer meds that are out, this is a primary factor in why they're becoming used extensively in diabetes care, their effect on cardiovascular risk. Big word there at the top, it's pronounced thiazolidinediones, and we just call them TZDs for short. Rosiglitazone or Avandia, Actos, pioglitazone, those are the two common ones now. You may recall troglitazone, Rezulin, was the first TZD that was on the market a while ago, but it was removed from the market because it led to hepatic toxicities. And fortunately, with Avandia and Actos, no hepatic issues have really been noticed at all. However, it's still highly recommended that liver function is monitored and tested continually while taking these drugs for that reason. TZDs are strong insulin sensitizers, and they stimulate glucose uptake in the muscle and fat cells, reducing hepatic glucose output. Now, a major adverse effect in the TZDs is weight gain through edema, especially in the ankles and legs. So therefore, TZD use is contraindicated, like in congestive heart failure patients or those who are susceptible to congestive heart failure. And also some other effects that have been noted with TZD, can lead to some anemia, so blood tests may be required. And if you have some younger female diabetic patients, TZDs decrease the effectiveness of oral contraception. Another old reliable are the alpha glucosidase inhibitors. Precost and Glycet are the common ones, and they work by inhibiting the breakdown of disaccharides to monosaccharides in the intestines. So just makes it a little easier breakdown, a little easier passed on through the intestines, so less glucose released to the bloodstream. Some recently introduced medications, by recently I mean probably within the last 10 years. Amylinometics came out, Simlin is the big drug there. Was one of the first ones. We have our incretin agents, GLP-1 receptor agonists and DPP-IV inhibitors, came out also about 10, 12 years ago. And the newest kid on the block, the most recent that came out last year, the sodium glucose cotransporter 2 inhibitors. We're going to look at each of these individually in a little more context. First, amylin acts on the brain to suppress post-meal glucagon. Therefore, it's going to reduce hepatic glucose output. Now, we also see that amylin, natural amylin, regulates gastric emptying. Gastric emptying, as we know, is the movement of food from the stomach into the intestine. And if the carbohydrate stays in the stomach longer, they can be converted to glucose and enter the bloodstream in a slower, more gradual manner. Okay, so amylin also acts as a satiety factor to decrease food intake. So if that's naturally occurring amylin, we see diabetics tend to be deficient in amylin. Okay, so we have what are called amylinometics. Amylin mimics the effect of natural amylin that impact glucose appearance. Okay, in response to a meal, amylin is co-secreted with insulin in normal glycemic individuals. Insulin helps regulate glucose disappearance, where amylin helps to regulate glucose appearance. And it does that by decreasing glucagon production. Like I said, in diabetics, amylin is deficient. Type 1, it's almost totally deficient, completely deficient. Type 2, there's some basal levels that appear normal, but they fail to secrete more in response to a meal, so they're inefficient. Okay. Without amylin, most patients with diabetes produce extra glucagon. When they eat, this can contribute to postprandial glucose spikes, blood glucose spikes, or excursions, as the term is used. When taken with meals, Amylin suppresses the extra release of glucagon by the pancreas. So the big control here is controlling postprandial hyperglycemic excursions. One of the reasons for this, it's been a lot of, it's been highly noted that these postprandial excursions lead to some macrovascular and microvascular complications of diabetes. So major treatment management is to get these postprandial levels in control. And amylin is one medication that helps to control these excursions. So the main benefit, decreased postprandial excursion. It decreases A1C levels, 0.5 to 0.7%. And also there is some weight loss note, about 1 to 1.5 kgs. I'm sorry. Here is the Pramlintide. Here's Amylin looking at the changes in A1C levels from baseline. You can see this is 2 different dosages of the medication, and you can see the drop about 0.6 from baseline, 0.6% from baseline at the 120 microgram dosage, 0.4% at the 90 milligram dosage. With the 120 microgram dosage, this was statistically significant values from baseline. Here we also see changes in weight with Amylin, and again, either dose here had statistically significant changes in body weight from baseline. That brings us to Glucagon-Like peptide 1 receptor agonists. Okay, the GLP-1 receptor agonists, these are some of the common names, generic names. Exenatide was the first one on the market, goes by Byetta. Liraglutide is a newer one that has shown some really nice cardiovascular benefits we'll talk about in a second. Dulaglutide is another new one that has a longer acting action, goes by Trulicity. These are the major GLP-1 receptor agonists. Now, first, we have to understand the action of GLP-1. GLP-1 is a naturally occurring gut-derived hormone. It's released in the intestine. Okay, and its main actions, okay, are to increase glucose-mediated insulin secretion. Now, it's only going to lower glucose until blood glucose levels are lowered. So here, it's glucose dependent, as opposed to sulfonylureas, which are glucose independent. So therefore, GLP-1 doesn't promote hypoglycemia. GLP-1 also helps to decrease postprandial glucagon secretion. And so it's going to decrease HGO and therefore postprandial hypoglycemia. It also works to slow gastric emptying, which we just talked about. It promotes satiety. It decreases food intake. Even may improve beta cell function, beta cell mass or function. So that's some speculation there, but these are some actions of naturally occurring GLP-1. You say, well, wow, if this is naturally occurring, this is like a natural diabetes defense mechanism. What's the problem? Well, the problem is GLP-1 has a very short half-life. And there's an enzyme that's called DPP-IV that counteracts the effects of GLP-1. So we have the intake of food. GLP-1 is naturally released when it releases. It produces insulin, or has insulin, causes insulin to be released from the pancreas, and also inhibits glucagon to be released. That's what we've just talked about. Now the problem is DPP-IV is hanging around, and once it senses GLP-1 out there, it limits its action. So the half-life for GLP-1, naturally occurring GLP-1, is very short because of the action of DPP-IV. So someone very intelligently said, hey, let me make a drug that does the same thing as GLP-1 that doesn't react to the effects of DPP-IV. And that's what they did. They came up with these, the GLP-1 receptor agonists. And they were originally approved to be used in combination therapy. Back in the mid-2000s when they first came out, they could only be used in combination therapy with metformin or other sulfonylureas. Okay. Especially after a failure of metformin as monotherapy. Now, in healthy and type 2 diabetic individuals, the GLP-1 receptor agonist reduces A1C levels by 1.1, 1.6%. It also works to reduce postprandial hyperglycemic excursions, okay, slows gastric emptying, everything that the naturally occurring GLP-1. It reduces food intake and actually leads to weight loss. Okay, there is a satiety factor built into it that reduces food intake and leads to significant weight loss. A low incidence of hypoglycemia, and this is because of the glucose dependency. Remember, sulfonylureas were glucose independent. They just kept producing insulin no matter what the glucose levels did. GLP-1 receptor agonists respond and are to glucose levels, so they're glucose dependent. The big thing with the GLP-1 receptor agonists, especially the new one, liraglutide, and results from the LEADER trials. LEADER was a major study on liraglutide, and it stands, I can't remember the briefing offhand, but it's liraglutide in diabetes extended results. Can't remember the exact title here, but showed significant reduction in the rate of major adverse cardiovascular events in type 2 patients with elevated cardiovascular risk. So where at one time, glucophage itself was considered the main diabetes drug, the main diabetes go-to drug, some of these newer drugs are now trying to make claim for, hey, I can do this too. And liraglutide is one that's shown a lot of promise. Exenatide, this is the Byetta, one of the GLP-1 receptor agonists. You can see here, this is change in A1C from baseline. And in the first bar here, you can see this is exenatide and metformin combined, a significant drop in A1C levels. Here we have exenatide and a sulfonylurea, and then here all three of them were combined. Still, the major decreases in A1C levels were reported. And here, so then we said, more importantly than just reducing the A1C levels, how many patients got into that optimal category of less than 7%. And here you could see about 50% of patients with the higher dosage of Exenatide with metformin reduced themselves, almost 50% reduced themselves into the less than 7% category. So a lot of promise there. Now, back to this diagram, we see here's DPP-IV doing its action on GLP-1. Well, some different people who said, well, okay, some people said, let's synthesize GLP-1. Let's make a GLP-1 analog. Someone else said, well, why don't we do something that inhibits DPP-4 and allows GLP-1 to do its job naturally? So, of course, someone came up with a DPP-4 inhibitor drug. It inhibits the DPP-4 enzyme, which in turn allows GLP-1 to inhibit glucagon release and promote insulin release from the pancreas. Two of the main DPP-4 inhibitors are Januvia and Onglyza, Sitagliptin or Saxagliptin, and both of these preserve the action of GLP-1. And so they're promoting insulin secretion in response to a meal. Specifically, in response to a meal, GLP-1 is released, which inhibits glucagon release, which in turn increases insulin secretion, decreasing gastric emptying, and decreasing blood glucose levels. Everything we saw before. That's what this drug does. It allows GLP-1 to do all its naturally occurring functions. Now, other benefits, we see a decrease in fasting plasma glucose as well as hemoglobin A1C levels, okay, about 0.5 to 1%. We see a reduction of the postprandial hyperglycemic excursions. Again, lowering those postprandial hyperglycemic levels is key for preventing the micro-macrovascular complications. It slows gastric emptying, okay, but there's no effect on satiety here. It's weight neutral. There is also noted a moderate reduction in cardiovascular events. Okay, not as much as there was by liraglutide or one of the drugs we'll see in a little bit, but there's still some reduction. So again, you can't go wrong with being on this medication. So here's the effect of sitagliptin monotherapy on 2-hour postprandial glucose levels in patients with type 2 diabetes. And the big thing here is two different doses, okay, 100 milligrams and 200 milligrams, and you can see the drop in plasma glucose levels. Okay, here you can see they give the results here in millimoles per liter, which is a more European and Asian journals will use this measure a lot more, and the conversion from milligrams per deciliter to millimoles per liter is 18. So if I am at 1 millimole per liter, I'm at 18 milligrams per deciliter. Okay, so these values are giving millimoles per liter. And you can see with the higher dosage of sitagliptin, a much more significant drop in plasma glucose levels. Okay, so that brings us to the final drugs we're going to talk about and the newest kids on the block, the sodium glucose cotransporters, 2 inhibitors. And the big ones you might recognize are, empaglifloxacin is the big one, Jardiance. And Invokana is the other one that's kind of popular now, canaglifloxacin. They're the 2 big ones that are out there. But sodium, this SGLT2 inhibitors improves glycemic control with no major risk of hypoglycemia. Again, a major advantage. We see significant changes in A1C levels. Okay, the big results from what we call the EMPA-REG study, the empagliflozin action study, which came out just last year, indicated a 38% relative risk reduction in cardiovascular mortality. Obviously, for those that work in cardiac rehab, we know that's pretty significant and pretty strong statistical significance there too. But SGLT2's inhibitors work by preventing reabsorption of glucose in the kidneys, and it promotes, therefore promoting glucose excretion. So it's going to help to lower blood glucose levels. Additional glucose control is manifested by increasing insulin sensitivity, decreasing gluconeogenesis, and improving first phase insulin release from the pancreas. You really need to understand that this first phase insulin release is essential in controlling and managing diabetes, or managing blood glucose levels, especially acutely. And getting control there really helps the process. Here is from data from the EMPA-REG study. You can see, besides lowering glucose, insulin levels, the decrease in the oxidative stress, decrease in weight, decreased sympathetic nervous activity, decrease in blood pressure, arterial stiffness, albumin levels. Okay, as most of you probably know, patients with diabetes, once they start showing higher levels of albumin in the urine, are susceptible for nephropathy. So, so the SGLT2 inhibitors can also help be almost prophylactic for albuminuria as well. Decreasing uric acid also helps to, I think this is a misprint on their slide. It probably should say decrease LDL cholesterol, as it increases HDL cholesterol and then decreases triglycerides. So there's a lot of effect here on cardiovascular risk that, as we know, diabetes being a primary risk factor for cardiovascular disease, this SGLT2 inhibitors are really making a play for becoming the go-to diabetes drug. Here is some other data just showing the effects of empagliflozin, and here's changes in baseline A1C levels. You can see here are the baseline A1C levels, and you see the reductions. Okay, 0.6, about 0.6%, and then baseline weight changes, 1.5 kilograms to 2 kilograms, 95% confidence intervals for both. So, pretty decent numbers there, and so that pretty much says I have one pill for blocks fat, one pill to block carbs, and one pill that blocks the kitchen door. Probably the ultimate test for any diabetic patient is blocking the kitchen door. And that concludes my presentation. And Tim, did you want to take over?
All right, thank you, Shell. We have some time right now to answer a few questions from the audience. If you do have a question, we ask you to type it in the question tab, and give a chance or some time for Shell to answer some of those. I do see one question here, Shell.
Yeah, it's stuck on my.
Okay.
I can't see all of it. It says, doesn't Stimulin injection interfere with recovery from hypoglycemia when patients are treated with oral dextrose? Wow. That I cannot answer. I apologize. I'm not familiar with that role, that part of it. I would assume GLP-1s are much safer, but especially with everything the results that they've shown to date. So I can't answer that question, first part of that question, but looks like here's another question. Does metformin cause hypoglycemia? No, it does not. No, it doesn't. And that's because it's glucose dependent and not glucose independent.
We can just give it another few seconds to see if anyone else wants to type in their question. I do want to remind the audience that I will have a link to the video recording within 24 hours of this broadcast. I will also be emailing everyone the PowerPoint packet as well as the certificate of CEU. Again, that'll be in your email within 24 hours.
There is one more question, Tim.
Okay.
It says, out of all the new kids on the block, how would someone choose which one to prescribe? Well, obviously the prescribing physician would have the big role in that. A lot depends on, are they dealing with postprandial excursions? How high is their A1C level? Are they exercising on a regular basis? How good is their diet? And I hate to use the word diet. Selective eating is a better term to use, or nutritional management plan. But all that goes into play when they're deciding, when a physician decides which drug they're going to prescribe. Does the person have multiple cardiovascular risks? If they do, well, God, the SGLT2 inhibitor might be the go-to drug for that, even over glucophage. But again, I'm not a physician. I couldn't, I wouldn't say that to a patient. So, but that's where I would go with that one.
See one more question here, Shell.
Let's see. I'm not seeing it yet.
We still see a lot of basic insulin regimen with Lantus and Novolog. Any thoughts on this? And is it still effective?
Wow. That's a loaded question. I wish I could answer that question. Yeah, I can't answer that question. To be honest, I wouldn't give it justice. I'm not as familiar with Lantus and Novolog and their actions. I know, again, are we talking type 1 or type 2? Are these be given to type 2 patients in combination with oral agents, or is it just individual insulin therapy? I just can't answer that. I apologize.
Okay, I think that's all the questions that we have. So at this time, I'd like to thank everyone for their attention and participation with this webinar. We hope to see you back at our next one. Until then, take care, and we will hopefully see each other later. Goodbye, everyone.
Thanks, Tim.
Bye, Shell.